Good afternoon, everybody who has joined me for this afternoon CPD Snippets. Today, I'll be talking about fibroid and fertility. So it gives you an overview of how the day-to-day dynamics are handled in terms of managing fibroid as a cause of infertility or subfertility. So in this presentation, I will touch base with types of fibroid, which are clinically important, and how fibroids affect fertility, and how they cause subfertility, and what are the investigative modalities in the UK setup, and critical evaluation of current methodologies of investigative modalities, and also the options to treat fibroids, the present and future, and few case studies. And then I'll take question and answers. So just to update you, there are at least 7 different types of fibroids, but from a fertility point of view, there are 3 important types of fibroids. One is called as type 0, where almost 100% of the fibroid is protruding inside the uterine cavity. So that is T0. The next one is type 1, where most of the fibroid, or more than 50% of the fibroid, is projecting into the uterine cavity. In other words, it is distorting the uterine cavity. Type 2 is more than half of the fibroid dimension is into the uterine musculature, and less than half is into the uterine cavity. So just to make it more simplified, in this picture on your left, the 100% is submucosal intracavitary type 0 fibroid. The second one is protruding by 70%. And the third one is protruding into the cavity by 40%. And one on your right side is showing the impact of fibroids on fertility. So, for example, the submucosal fibroid with type 0 will have highest impact on fertility outcomes. And the type 1 and 2 have less severe compared to the type 0. So in this MRI picture, there are 2 MRI pictures of 2 different patients. One, you can see the white line continuous from fundus to the cervical canal. On your right side, you can see this is type 2 fibroid with about 20% projection into the cavity, and the cavity is distorted. So the type 2 fibroid, only a minor amount is protruding into the cavity. One on your left side, even though the fibroid is in the uterus, but it is not protruding into the cavity. The endometrial cavity is not disturbed compared to the right side, where endometrial cavity is disturbed. So these are the 3 investigative modalities available in the UK as of now. One on the left side is ultrasound. So the ultrasound is showing type 0 submucosal fibroid. And the rest of this triangular configuration is uterine cavity. So it's situated right at the top of the uterus, attached to the fundus. This one is called as SIS, Saline Infusion Sonography. So the sonographer injects saline, and then the fibroid gets delineated and clearly seen. This is semi-invasive intervention. This one on your right side, is MRI picture. So the MRI is non-invasive, and it shows clarity in terms of classifying the submucosal component of the fibroid. So in this, if you draw an imaginary line, it's more of submucosal. So it is type 1 submucosal fibroid. And also it gives you an idea if a surgeon decides to go ahead and remove, what would be residual myometrium left following resection of this fibroid. The next one is hysteroscopy. With the advent of miniaturized hysteroscopes, it is possible to perform outpatient hysteroscopy with or without local anesthetic in less than 5 minutes and get a color picture and also more deeper understanding of the nature of the fibroid, type of the fibroid, and suitability of this fibroid in achieving complete resection and optimizing fertility. So in my view, showing the 3 different modalities, in my day-to-day practice, I use ultrasound as a screening test. Once ultrasound is available, in order to understand the depth of penetration or depth of myometrial involvement, I use MRI. And once I have done 2 investigations, the next step is to perform hysteroscopy, diagnostic hysteroscopy, to understand the nature of the fibroid and then suitability for resection. These are the 2 modalities available in the UK as of now. The one on your right side is the bipolar resectoscope. So later I will show you the video. But the reason I'm showing you this is when we use bipolar resectoscope, it uses heat energy to cut this fibroid. Now, if you remember type 1 and type 2, you will have to cave in to get the most of the fibroid out. Now, the problem is it will leave a residual myometrium which has been damaged, injured by the heat energy. Compared to that, the latest technology involves use of mechanical cutting blade, where you introduce this device called as MyoSure, and it sucks the tissue in, and then the blade cuts it and the tissue gets sucked into the container. The beauty of this is it doesn't cause thermal damage to the adjacent endometrium. The only problem I encounter with this MyoSure device is it is very good if the fibroid is of a softer density. But if the fibroids are firmer, they're calcified, the blade gets blunt, and it does, the blade is costly, so it may have to be replaced, and from cost wise, it doesn't make sense, and in which case we may have to recourse to the bipolar, and in some cases I may start off with MyoSure and end up with bipolar resectoscope. This is just to highlight the point I was talking about. So residual myometrium following type 2 fibroid resection. So what I'm demonstrating here is this is the submucosal fibroid, which is presumed to cause subfertility in a given patient. So the idea is to resect the fibroid in its entirety. So when that is achieved, you may end up with this kind of defect in the uterine musculature. So the end result is a defect or a niche in the uterine musculature, and that is depicted by these yellow lines. So the more we are doing, the more number of patients are having problems in terms of uterine rupture in mid-trimester or uterine rupture late in pregnancy, because when we cut the fibroid, the base of the fibroid is left open. So generally up to 2 centimeter type 1 and type 2 fibroid is safe to resect. Anything more than that, if you live with a defect, there's a risk of uterine rupture during pregnancy. So patients need to be aware of this, as well as clinicians who look after such patients also need to be aware of this. So these are the two cases published, one in British Medical Journal, the other one in Turkish Journal. So what I'm depicting is both of these patients have had hysteroscopic resection of fibroid using thermal electrical energy. So one on your left side, she had hysteroscopic resection, fell pregnant at around 18 to 19 weeks. She presented with pain and then collapsed, and then laparotomy showed uterine rupture at the fundus where her fibroid was resected. One on your right side, it's a Turkish journal publication. She also had a hysteroscopic resection, and at that time they suspected perforation but didn't close it, and she fell pregnant, and then she carried to term, and then she needed cesarean for obstetric indication. And when they opened her up, they realized that there's a unhealed uterine defect seen. So the summary of these two cases is that when type 2 and type 1 fibroids are resected, there's a risk that patients may have residual myometrial damage, which may put them at a risk of uterine rupture in late mid-trimester to third trimester of pregnancies. Now, there are conservative options to manage fibroids available in the UK. One on your left side is called as uterine artery embolization. So it is very good. It is endorsed by NICE, and we use it day-to-day clinical practice. But one needs to be aware when such modalities are used in patients who later on aspire to become mothers. Because what happens in uterine artery embolization is it not only shrinks the fibroid, but it also cuts off blood supply to the uterus as a whole. So there is a risk that these patients are also at an increased risk of uterine rupture compared to the patients who did not undergo this procedure. Just briefly, there is a limited access available to some of the patients in the UK called as MRG FUS. So M stands for magnetic resonance guided focused ultrasound treatment. So if patient satisfies all the criteria met for MRG FUS treatment, she can have it in few designated centers. But the patient selection is very strict, and most of the patients do not fulfill the criteria to get this treatment done. But if they do have this treatment, it is much more safer compared to the uterine artery embolization. Because it is focused, it only destroys the fibroid. In other words, it doesn't affect the uterine musculature. And this is the newest technology introduced into the UK market, FDA approved, and currently being trialed in 10 of the UK NHS hospitals. So in this, the black device is the ultrasound probe, and one on the right side, the white and purple one, is where the ultrasound will depict the fibroid, and then this is an engaging system where the needles will be passed under ultrasound guidance, and then it releases heat energy. So it's more direct guided treatment of heat energy to shrink the fibroids. It's done under sedation or general anesthetic as a day case. So there are post-treatment pregnancies have been published, and so far the data is promising. Even though the system usage does contraindicate future pregnancy aspiration as a contraindication for this treatment, but there are published papers suggesting safer outcomes for the mothers. This video shows electrical energy being used to cut the fibroid. This is very traditional way to resect the fibroids. Okay, so this is MyoSure technology. So it's very good for type 0 submucosal fibroids, and when the fibroids are soft. And when there are many fibroids, MyoSure is better technology to clear the submucosal fibroids, because it doesn't leave any residual tissues floating into the uterine cavity. And also the surrounding endometrial damage with MyoSure is extremely low compared to the electrical heat energy, the traditional way. Hope you enjoyed the presentation.